Good morning. Good morning from SSF. My name is Jens Chapman. Today is November the 4th, 2020. It's a momentous couple of days. Welcome to our STED Talks today. We have a great lecture today. Dr. Rahman will talk about regional spine anesthesia and an emerging topic. As is our custom for the first half hour, we have a couple of interesting cases. And I want to thank our wonderful fellows and Dr. Skuyen who put those together. And without much further ado, we'll jump right into the fray. Dr. Ravi Nuh is one of our fellows, and he has a perplexing case to show. It's not immediately necessarily connected to regional spine anesthesia, but we all thought that you, as our viewership, would like to see some variety of cases. Ravi, take it from here.
Thank you, Dr. Chapman. So this is a case that challenged us for several weeks, so I'm happy to bring it to your attention. This is the case of a 65-year-old female, history of hyperlipidemia, GERD, hypothyroidism, and morbid obesity. She presented with a history of multiple spine surgeries. About 10 years out, she had a 3-4 laminectomy that was complicated by infection, required a wound revision. She had a Tlip at 4-5, and then she had a revision laminectomy at that level for some continuing low back pain with right lower extremity pain. She presented to clinic with disabling low back pain. This was her most concerning symptom in the low back. She also reported pain in the right lower extremity numbness and tingling, and then pain-limited weakness in the right leg as well. On physical exam, she had an intact motor exam and mild sensory deficit diffusely in the right lower extremity, non-dermatomal, and no pathologic reflexes. Her imaging at this time showed her previous surgery, a 4-5 Tlip. It also showed 18 degrees of a right convexity coronal scoliosis between T12 and L3, and lumbar lordosis of 59 degrees. Pictured here, we have a CT and as well as a lumbar plane films showing a 3-4 spondy with 7 millimeters of translation, about a grade 1-2. MRI imaging at this time showed lumbar 2-3 central and lateral stenosis, as well as significant stenosis and lateral stenosis at 3-4. The top right picture is 2-3, and the bottom right picture is 3-4. And as you can see, highly significant both central and lateral stenosis at these levels. So patient was consented for a 2-stage procedure. Stage 1 would be thoracic 10 to pelvis posterior spinal fusion, and stage 2 would be anterior and lateral interbody placements, planning for a 2-3 and 3-4 lateral interbody placement and a 5-1 anterior interbody placement. Pictured here is postoperative films after stage 1. This patient had a high pelvic incidence of 80, and we thus aimed to produce about 60 to 65 degrees of lumbar lordosis, which was consistent with current age-appropriate guidelines. We also placed dual pelvic fixation with S2A1 screws and traditional iliac screws, and we used a multi-rod construct with the dual head screws proximally. We also performed a Smith-Peterson osteotomy at 2-3 and 3-4 just to be able to get more lumbar lordosis at those levels. And as you can see here, she corrected pretty nicely from the posterior approach. No issues during her initial admission for stage 1. She did have about 3 to 4 days of severe unremitting abdominal pain that actually resolved after holding all opiates. So she was diagnosed with narcotic bowel syndrome at this point and ultimately discharged to rehabilitation. We brought her back a month later for the second stage of her procedure and performed a lateral 2-3 and 3-4 interbody fusion that was performed first. And then urology placed a stent in the ureter for intraoperative protection. During the anterior approach, it was highly challenging. It was a combined approach with a vascular surgeon colleague. This patient had a very large habitus. There was significant bleeding, and she also had a history of previous abdominal surgery that left significant adhesions. However, the interbodies were placed without issue, and as you can see here, these are the postoperative films with adequate hardware placement and no issues in terms of her implants. In her postoperative course, post-op day 3, she began complaining of severe and unremitting abdominal pain. Given that she was previously diagnosed with narcotic bowel syndrome, narcotics were held with mild benefit. By the weekend, she started doing a lot better, and we thought that she had essentially rounded the corner. But then she reported that this abdominal pain came back post-op day 7. CT imaging at this time showed a small retroperitoneal hematoma that did not look active in nature, as well as several what we thought at the time were post-surgical fluid collections, given that she was very, very deep during the anterior approach. So we continued to hold her narcotics, however, to no benefit. Abdominal pain continued at post-op day 10, and we obtained an ultrasound at this point that showed an expanding pelvic fluid collection pictured here on the right. This was measured at 12 by 7 by 7. Repeat CT with contrast at that time also showed now evidence of emerging mild hydronephrosis. However, patient had no signs of renal failure in terms of her creatinine. As you can see pictured right here is the quite large left pelvic fluid collection. And in the picture on the left, you can see some evidence of hydronephrosis in the left kidney. So we sent this patient for CT-guided IR drainage of the pelvic fluid collection. Immediately post-operatively, the patient did report some benefit in terms of her abdominal pain. This patient is actually still on our wards, and we are awaiting lab and culture analysis for this pelvic fluid collection. Gram stain was negative, and we have a low suspicion for infection, just given that she has no laboratory or clinical signs of infection, and the incision has no issue. So we performed a literature review for pelvic fluid collections that can present after anterior lumbar surgery, and we did find a case series of Chylo retroperitoneum following anterior spinal surgery. And this can be a rare complication, and about 10 to 20 cases have been reported in the literature. This is secondary to lymphatic channels that are present all around the great vessels in the low lumbar area, which is exactly where our surgery was, and retraction and destruction of these channels can ultimately lead to the formation of a lymphocele. This lymphocele can continue to expand over several days and ultimately, if large enough, cause adjacent organ compression as well as hydronephrosis and compression with extreme symptoms, as we saw in our patient. As you can see here, a nice illustrative diagram in terms of the retraction injury that can occur to these lymphatic channels. This study by Dr. Escuyan also showed an algorithm that can be used in these cases when patients have either a CT finding or symptomatic complaints of abdominal fluid. And the initial algorithm shows that we can first assess how large the fluid collection is and if it's symptomatic in nature. This algorithm suggests that if it's very, very large or if it's symptomatic, that we should consider IR placement of a drain for symptomatic benefit. In terms of laboratory testing, other possibilities are obviously an abscess formation as well as a urinoma. We also obtained a pyelogram on this patient that did not show any signs of a developing urinoma, and we did send for creatinine, which is the best test in terms of testing if you could be dealing with urinoma fluid collection. So in terms of our patient, she did improve significantly. We're still awaiting laboratory testing to see if this was indeed a lymphocele, but definitely an interesting and puzzling case in terms of postoperative fluid collections that can develop rarely after ALIF procedures.
Well, thanks for sharing that interesting case, Ravi. There are many things to discuss. Obviously, in the interest of time, I have to kind of just fast track a couple of things. So what kind of lab values do you expect to come if this indeed is a lymphocele?
This is a little unclear. I think there's a range of lab values that might be possible. I think we can look at LDH, and we can it's kind of a diagnosis of exclusion.
Can you go back to the CT?
Yeah.
Okay, so it's more diagnosis of exclusion. Rod, in your experience, are there any non-surgical things that can be done, like albumin management, nutritionally, anything like that, electrolyte management?
No, I mean, this is a, you need a drain if they're symptomatic, and they can get quite large. In fact, we had one patient that almost went into renal failure. It causes like a compressive mass effect on everything. So I think the management is either, once it gets to a certain size, it's either drain, or we actually had to do a peritoneal window where you connect the peritoneum to the retroperitoneum so it can absorb the fluid. And you'll see like this drain will dump out, 500-600 cc's a day. So I think once you get to a certain point, you have to do a procedure.
How long do you keep these drains in?
We had one patient that had it in for 6 weeks.
Wow, okay.
Yeah.
And again, the same question. Do you have to give them, harping on the nutrition factor, do you have to give them hyperalbumin kind of transfusions or extra nutrition or something like that?
No, we didn't. In our experience, usually these patients have extra nutrition, if you know what I mean. Their nutrition isn't an issue.
Can it surgically be avoided during anterior access surgery?
So usually the thing that we've seen is that, I don't know where the incisions did. Were there two separate? There was an ALIF at 5.1 and an OLIF, like lateral approach.
Right.
We actually saw it in L4-5 and L5S1 cases, so I think you probably got it down low.
Yeah, our ALIF was 5.1.
And you can see where the fluid collection is. There's a big lymphatic channel there that I think you can disrupt when you're doing it, and so you develop basically the lymphatics just kind of back up. So.
Let's see, with Dr. Rahman, can you hear us? Atta, can you hear us?
Yes, I can, yes.
Thanks for being willing to talk today, and Dr. Kudorov also from anesthesia. So obviously, this is a case that's very pertinent towards pain management. What do you know about this narcotic bowel syndrome? So this is something new to me, and this will be very pertinent to your case or to your discussion of alternative medication management. Who's at risk for this? Have you ever heard of this?
I think that, so I think this is sort of in the continuum of the just sort of opiate-related side effect of the constipation. And also, I think there's two kind of phenomenon here. So there's opiate-related constipation and then opiate-related, opioid-induced hyperalgesia, where, more and more opiates, increase your tolerance for them, and you just don't have quite the same effects. So you have more and more pain, and you kind of have to escalate the dose of opiate. And I think kind of in parallel to that, you often see increasing degrees of ileus and things like that. So I have not heard of the phenomenon specifically you're talking about, but I think that it kind of would fall in line with those other two phenomenons I talked to you about, the opioid-induced hyperalgesia and the opioid-induced constipation.
Okay, so this is, again, one of those, there are two key things that I immediately take out of what you said. There's this kind of a weird paralysis phenomenon that can deactivate the bowels, but then the other fact that you just mentioned is hyperalgesia syndrome with more and more opiates. We actually struggle with that ever so often, and I think we have a patient with that right now. So maybe to discuss more. Any other thoughts, Rod?
No, I mean, I think for us, I wanted to illustrate this case because I think the patient had a lot of back pain and then ended up getting, I think, probably 2 too much narcotics and got backed up. And then that's kind of cascaded on to have other issues. So I thought it was a good example of, where it's kind of hard for us sometimes to manage the pain from surgery and what potential complications can happen with too much narcotics.
And again, yeah, one other question on the chat room, Dr. Baz, Teresa Baz, she was asking about dietary things, but I think you addressed that already. So electrolytes, sodium, et cetera.
Yeah, I mean,
albumin doesn't help.
No, this is purely
Low-fat diet? No fat diet?
No. You can see on the CT scan there's plenty of nutrition.
Right. Who's going next? Dr. Puriya Knaim is going to come up. And thank you, Ravi.
Good morning, everyone. My name is Puriya Gayomi, one of the spine fellows here at the Swedish Neuroscience Institute. I have two cases. I'm going to try to keep them short so we can get through both. The first one we partially discussed 2 weeks ago, but this is kind of an update on what has happened since then. Patient is a 63-year-old female, multiple comorbidities, sustained a ground level fall. 2 to 3 weeks prior to her presentation, she was found to have a T12 burst fracture. She has a history of L4-5 Tlip using these cortical screws that were placed at an outside hospital years ago. She has no bowel or bladder issues. She has no radicular symptoms. She ambulates with a walker at baseline, and her BMI is 43. On imaging, on her CT scan, if I can get my mouse here. Once again, this kind of shows that burst fracture at T12 with some retropulsion and loss of height. And this is the sagittal view. And also on her MRI, you can see that there's evidence of stenosis at multiple levels and severe degenerative changes of her lumbar spine, kind of, again, at multiple levels, including at the level of her previous Tlip. Decision was made to take her to the OR because she had ongoing pain that lasted a few weeks. She had inability to ambulate on presentation. She had multi-level stenosis on her MRI, and given her body habitus, she was not really braceable. She underwent removal of her hardware, revision of her Tlip, and T9 to pelvis posterior spinal fusion, a reduction of the fracture. These are her postoperative images. She did well postoperatively. She was able to ambulate with physical therapy, and her pain improved dramatically post-op, and she was discharged home without any issues. Unfortunately, she came back to the ED about 3 weeks after her discharge. She sustained a ground level fall while she was trying to get out of her bed and go to the bathroom. She was admitted at an outside hospital, and per their report, she had no motor function at that time and bowel and bladder incontinence. We were kind of called about this about 2 to 3 days after she was hospitalized, and she was in the hospital for a few days before she was transferred to our facility. On our examination, she was 0 out of 5 in her bilateral lower extremities. She had no rectal tone and no sensation in bilateral lower extremities, and there was evidence of purulent drainage from the distal aspect of her incision as well. Her CT scan, it might be difficult to see, but there's evidence of fracture kind of at that UIV that you can see at the level of T9. And on the sagittal MRI, on the T2 cut, again, it's difficult and it's a little bit dark to see, but there's evidence of cord signal changes around the T8, T9 area as well. She was taken to the OR urgently upon arrival. There was copious amount of purulent material, kind of subfascial as well. She had multiple INDs and VAC changes. Her culture grew E. coli. After following multiple debridements, she was taken back to the OR for extension of her posterior spinal fusion to T6 with laminectomy from T8 to T10 and reduction of the fracture at T8 and 9. And this is kind of, these are the postoperative images from her second surgery. She was recently discharged to a nursing facility. In terms of a literature review, I was able to find this study that kind of talks about UIV fractures and UIV and long lumbar fusions. It was a retrospective cohort study. They had 27 patients with minimum of four levels fused, and they described kind of this UIV angle, which is a line at the inferior end plate of the UIV and the sagittal and the horizontal line. And patients who had a higher UIV, around 20, had a higher risk of UIV fracture. Also, interestingly, patients who were their fusion ended at L1 and L2 had a significantly higher risk of fracture at the UIV as well. Thank you. Thanks.
So, sobering case, difficult case. Major surgery again in very sick people with a very diffusely ailing spine. Priya, after you reviewed this case, what would you do differently if you're a practitioner now, a year from now?
Yeah, I mean, on the initial presentation, she kind of trialed in conservative management for a few weeks before actually presenting to us, and she had ongoing pain, wasn't able to ambulate. We tried to brace her, and she really wasn't able to tolerate that. So I think the decision to take her to the OR was definitely a good decision, and given that she had that prior surgery, multi-level stenosis and kind of degenerative scoliosis on presentation, I think a long segment fusion was definitely the right choice for her. It's unfortunate again that I think the fracture most likely was secondary to the fall that she sustained. She immediately had kind of loss of function in her bilateral lower extremities, and it's unfortunate that it happened. She's multiple comorbidities. She's a larger lady, and the infection, unfortunately, is also, that's a devastating complication in this setting. I think the management was appropriate. She was taken back to the OR immediately when she came back to the hospital. So I don't think there was much that I would do differently.
Dr. Roland Kent, are you still live on the panel forum?
Yes, I am.
Great. Thanks for dialing in. You gave a wonderful presentation 2 weeks ago about robotics and how you kind of came towards that. In a case like this with a very significantly ailing patient, can a robot decrease infection rates? Would you have done more levels, and would the robot have helped somehow in that surgical execution? Thanks.
Yeah, I mean, I think that's an excellent question. And obviously, it's hard to look backwards and say, would this patient have benefited from something differently? I think where the robot would help in this case is I do think we preserve the soft tissues that help maintain the spine. And then the other way that the robot helps in this case, in my mind, is, and I don't know if it helps with the fractures through that upper instrumented level, but, much larger instrumentation with much more rigid fixation, even in a osteoporotic spine. So in these cases, I feel fairly comfortable running that upper screw close to the end plate and then even getting bicortical purchase. And I think we would need a lot more data to actually show that prevents this from occurring. But I think maintaining the soft tissue structures, which you can do with any navigation platform, whether it be a rigid robotic arm or otherwise, I think is useful for continuing to get a good blood supply to that upper instrumented level and perhaps reduces the rate of fracture, but a lot more data is necessary. It obviously helps with the revision portion of this.
Thank you, Roland. I have a question that goes back towards your trauma time. You're a decorated surgeon and you're in war theaters. Gram-negative infections are the bane of our existence frequently. Why do they happen? Is that a direct contamination thing? Is there a transmigration of the intestinal system to our blood system, and with that then to a wound cavity? So give us a little insights that you gained from your trauma history in terms of gram-negative infections.
Yeah, boy, I mean, I think from the trauma side, gram-negative, or I should say that the wounds themselves, especially with open spinal wounds, which I saw a lot of in Afghanistan, et cetera, it's just a dirty environment. I mean, it hails back to my days working with infectious disease folks, and they'll tell you that there's, a low level of feces pretty much everywhere on the planet. And so if you happen to be somewhere and you step on an IED or get involved, most of our spine injuries were actually folks that were mounted in up-armored vehicles that drove over an improvised explosive device. And so we would see these open spine fractures when there would be shrapnel incurring in the up-armored vehicles, usually with a seated passenger, just because that would transmit the axial load along the spine. But, they were in an up-armored vehicle. You'd think it would be protected somewhat from these gram-negative contaminations. But in any open spine wound, I think our gram-negative infections come from the fact that the world is covered in gram-negative bacteria. And at the time of the trauma, they were unfortunately a contaminated wound. And then, of course, we, from theater to theater, do our best to irrigate those and clean it out. But there's lots of places to hide with an open spine wound.
All right. One more case. Thank you for your insights, Roland. So, Dr. Kayumi, one last case, and then we'll switch to our guest speaker.
Sounds good. This is a very different case. 49-year-old gentleman, history of IV drug use, has this prior history of L1 to pelvis posterior spinal fusion, unknown when and for what reason, and had a history of subsequent epidural abscess in 2017 that was treated initially with irrigation and debridement and eventually underwent revision of hardware in 2017. He is a very poor historian. He basically refuses to give us a history. We were able to kind of get this vague history of a motorcycle crash possibly 10 days prior to his presentation. He had ongoing back pain, and that's why he came to the emergency room. In terms of his past medical history, he has a long list of comorbidities and history of associated basically to his IV drug use, including hepatitis C, endocarditis, meningitis. He had a stroke that was actually secondary septic emboli from his IV drug use. He's end-stage renal on dialysis, and he has a history of MRSA bacteremia. He also had history of multiple irrigation and debridements of multiple joints for septic arthritis. His MRI was obtained. This is actually an MRI from 2017 I was able to find. You can see that there's evidence of an epidural abscess at L5S1. This is after this, he underwent revision of his hardware and then eventually underwent an L5S1 ALIF for discitis and kind of collapsed at that level. On presentation, he had leukocytosis and was basically septic. His major complaint was severe back pain and was pretty tender to palpation around his paraspinal muscles as well. He had no radiculopathy. He has a chronic foot drop on the right side, otherwise benign exam. And these are his images on arrival. As you can see, there's some evidence of lucency around his screws. Otherwise, he seems to be pretty solidly fused. On his MRI, it's difficult to see, but he has multiple fluid collection kind of more superficially, also deep around that L1 screw. He eventually was taken to the OR for irrigation and debridement and removal of his hardware. He was found to have evidence of an abscess at L5S1 as well that was debrided intraoperatively. He had multiple repeated debridements after that and underwent primary closure. He's still in the hospital and doing well. In terms of literature review, this was a retrospective case control I was able to find in patients above the age of 18 with diagnosis of epidural abscess. They were able to identify 1,000 patients. The recurrence rate was about 7%, and most common organism was Staph aureus. They were able to identify 3 independent risk factors for recurrence of epidural abscesses, and there were IV drug use and bowel dysfunction on presentation on the initial abscess, and also local spine wound infection. This was another study that kind of retrospectively looks at, well, I kind of lost my screen here.
Okay, carry on, finish. Yeah, here.
164 cases with spine infection. 62% of the spine infections were related to IV drug use. 7% presented with abscess only. Most common organism was MSSA, followed by MRSA, and then Pseudomonas. And the majority were in the lumbar area, followed by thoracic, and majority of them were single-level involvement. Thank you.
Great. Rod, tell us quickly, whilst we're switching to our guest speaker, what are your insights in this case?
I mean, I think, Corey, you did a great job at looking at the literature for this, because there's not, we know that these patients are high risk, especially the IV drug abuse patients. So for them to, and this patient was a setup, and so I think for me, the most important thing was going in, taking the hardware out, and getting plastic surgery, doing the wound vac, and opening things up. So great presentation, Poya.
So thanks for the cases, and thanks for your selection of the cases and discussions, Rod, and all of our visitors. Next is a great privilege to introduce Dr. Atta Rahman to the role of guest speaker here as a board-certified anesthesiologist with U.S. Anesthesia Partners. He trained at Baylor College of Medicine, so there's a Texas connection to the last presentation we had. He did a fellowship training in regional anesthesia at the University of Pittsburgh, and we're very proud to have him here now. He just for 2 years now worked in Denver, Colorado, where he applied kind of local blocks. So this is a new and hot topic, and this fits very well to the presentation of robotics and spine surgery by Dr. Kent, who's also online, and maybe he can weigh in later in the discussion phase. So, Dr. Rahman, we had a sound check with you before. We're looking forward to hearing new ways of how to provide analgesia in complex patients, and we saw some of the side effects of dealing with complex patients in the preceding 3 cases. So thank you, Atta.
Thank you, Dr. Chapman, for the introduction. Again, my name is Atta Rahman, one of the anesthesiologists with U.S. Anesthesia Partners of Washington, and I'm going to talk today about the Erector Spinae plane block, or ESP block, for spine surgery. I have no conflicts of interest to report, and today in the talk we're going to talk about how the ESP block works, how that mechanism of action can actually make it useful for spine surgery. And then based on my kind of experience of rolling this out for spine surgery in Denver, we'll talk about a few recommendations for starting up an ESP block program for spine surgery here. So the Erector Spinae plane block is basically a technique where with the ultrasound you identify the Erector Spinae muscle and the transverse processes below it. You then introduce a needle, contact the transverse process, and then deposit 20 to 30 cc's of local anesthetic in the plane deep to the Erector Spinae muscle and just on top of the transverse process. When I say Erector Spinae muscle, I think it's more correct to label it as the Erector Spinae muscle complex, because the Erector Spinae is actually composed of 3 muscles that kind of run the length of the spine. So the ESP block is a relatively new thing. It was first described by a group in Canada in August of 2016, and then it kind of sort of started to gain steam. There sort of started to be a few case reports about its use in breast surgery, rib fractures, cardiac surgery, things like that. And then by 2018, there were quite a few case reports and starting to be some retrospective studies. And then here in the last year, we are starting to see sort of some randomized controlled trials come out. And the main focus of the talk today will be the 3 randomized controlled trials looking at ESP block for spine surgery in particular. But in terms of the initial literature we had, so I finished fellowship in June of 2018. And so this was sort of kind of an assortment of the literature we had at the time. It was case reports, small case series, but the initial results there were looking pretty promising. So when I got to Denver, I talked to every surgeon I could, whether it was a breast surgeon, abdominal surgeon, spine surgeon, and told them about, hey, that there's this new block that might be of benefit to your patients. And thankfully for me, I met many spine surgeons in Denver that were willing to give it a shot. One of them that you all might know is Paul Elliott. I know that he trained at UW. He was one of my biggest advocates for using this technique in Denver. And I actually reached out to him this weekend in anticipation of this talk and kind of wanted to sort of ask him that, Paul, in terms of sort of the net summary of what we've done in the last 2 years, what are some of the points that I should kind of bring up during my talk? And he said that for him, sort of the takeaways from this block have been that his patients have been needing less narcotics intraoperatively. They've been having better pain control and needing less narcotics postoperatively. And as a result of those 2 facts, he's also seeing a lot less constipation postoperatively. In terms of the mechanism of action of this block, so there's functionally 3 mechanisms. In terms of abdominal surgery, there's the most useful element of its mechanism is that you have some degree of drift of local anesthetic into the paravertebral space. You also have some lateral drift to the lateral cutaneous branch of the intercostal nerve. But for the application of spine surgery, the majority of your local anesthetic is going to sit around the dorsal ramus. And so that's going to anesthetize the skin over the midline of the back, the paraspinal muscles, the ligaments of the spine, and the facet joints as well. So one of the really nice things about this block is that with a single injection point, you have a pretty significant cranial and caudal spread. So with a single injection point, you block multiple dermatomes. So the figure to the left of the screen is from a cadaver study from Cleveland Clinic, published last year. But the investigators injected 20 cc's of contrast at T10, and kind of the common thread that you can see between each of the cadavers is that although you have variation in terms of the exact number of dermatomes that were covered and which dermatomes were covered, that each of the cadavers had pretty broad spread in a cranial and caudal direction. In terms of what to inject, we'll go into this in a little more detail here in just a second, but this block is both volume dependent and concentration dependent. So if you're doing something that's a smaller operative incision, so you're doing something like a 1 or 2 level fusion or laminectomy, then 20 to 25 cc's of local anesthetic per side would be completely fine. If you're doing a much larger incision, something like a T10 to sacral fusion, for that you're going to want to deposit roughly 30 cc's of local anesthetic per side. Talking about bupivacaine, you would expect with the injection of bupivacaine that this block would last you somewhere between 12 and 16 hours. And so this block is placed prior to incision after the patient's gone to sleep. So, you have to factor operative time into that. And so kind of that leads me to my second point, which is, so if you expect bupivacaine to last you 12 or 16 hours, there are things that you can add to it to prolong its effect. And this is sort of a product of me being, having been a fellow at Pitt, but they were huge proponents of using additives to prolong the duration of peripheral nerve blocks. And so when I was doing this for Paul Elliott in Denver, I was often adding Precedex, dexamethasone, and epinephrine. And with that cocktail, we were getting 24 to 30 hours of block time. Other things that you could potentially add to prolong the duration of block are things like clonidine or buprenorphine, but those things have some significant side effects associated with them, with clonidine, hypotension, and with buprenorphine, postoperative nausea and vomiting. In terms of why concentration is important, this is a randomized control trial that was published from Turkey looking at mastectomy patients. Group 1 received a more concentrated local anesthetic, bupivacaine 0.375%. Group 2 received the more dilute local anesthetic, 0.25% Marcaine. And you can see that basically the more concentrated group required less postoperative opiate. There were fewer of them that needed rescue analgesia. And then sort of the big the takeaway here is the more concentrated local anesthetic group had lower pain scores, which were statistically significant at every measured time point in the first 24 hours. So kind of the takeaway point from this slide is that for ESP block, concentration matters. In terms of injection volume, this is a cadaver study where they compared what happens when you inject 10 cc's of local anesthetic or contrast versus 30 cc's. In the study, they injected at T5, and you can see that with T5 injection, the 10 cc group, there was no paravertebral spread, but the group that had 30 cc's, there was more paravertebral spread. It was a bit broader. And then the big thing, and I think the more useful kind of thing in terms of application to spine surgery, is the 10 cc group kind of covered a very small area, but the 30 cc group covered a very broad area. So if you were doing a very large fusion surgery, volume would matter. So that's kind of the takeaway point there. I'm going to talk specifically now about the 3 randomized controlled trials looking at the use of ESP block for lumbar spine surgery. Some factors that I kind of consider anytime I'm looking at published literature about new blocks or ESP block in specific is that, number one, what are they comparing the block to? Are they comparing it to local infiltration by the surgeon? Are they comparing it to no block? What is our comparator here? Number two, in these studies, what's the concentration of local anesthetic that they're injecting? Because as I just showed you, concentration matters. Number three, what is the level that they're injecting at? Kind of, as we can see from the last slide, is basically your local anesthetic, your paravertebral spread will be kind of concentrated around your point of injection. And then the degree of cranial and caudal spread you have is also sort of centered around your point of injection. So based on the incisions they're making in this literature, does it make sense where my ESP injection point is? And then I think the final thing that I kind of really take into account is these randomized controlled trials, most of them have been published in the last year, and the sample size or the study size in these publications is pretty small. So the control groups are 20 to 30 patients, as are the intervention groups. So I kind of just keep that in mind when I'm analyzing these things. But the figure to the right here is sort of a preview of coming attractions. So there has been a few case reports about cervical ESP blocks for cervical fusion surgery and for whiplash injuries and things like that. You can see here this figures from a cadaver study that they did with injection at C6 and C7. But as far as I'm concerned, with the body of literature that we have right now, there's a lot of danger in performing a cervical ESP block. And the reason that is that if you look at the area highlighted in red, this is with regards to the phrenic nerve. And so in this cadaver study, they found that 30% of the time when they performed the cervical ESP block at C6 or C7, they had involvement of the phrenic nerve. And again, if you're doing this unilaterally for like shoulder surgery or for a whiplash injury, unilateral blockade of the phrenic nerve is one thing. But if you're doing this bilaterally for cervical spine surgery, bilateral blockade of the phrenic nerve is, kind of a catastrophic outcome. That would basically guarantee your patient's going to be on a ventilator until the block has worn off. So that's why kind of the things that I'm going to talk to you is going to be more focused on the use of ESP block for thoracolumbar surgery than for cervical spine surgery. Again, with regards to the ESP block for spine surgery, you're going to be depositing your local anesthetic deep to the erector spinae complex and superficial to the transverse process. So your local anesthetic is going to basically block the dorsal ramus. That's going to anesthetize the skin over the midline of the back, the paraspinal muscles, the ligaments of the spine, the facet joints. Sort of one of the pleasant unintended consequences we saw of this in Denver was that from the blockade of the dorsal ramus and the blockade to the paraspinal muscles, Paul's patients were having a lot less spasm issues postoperatively in the first 12 to 20 hours while the block was still in effect. And so that was sort of a kind of a nice unintended consequence we had. All right, perfect. So in terms of the actual studies themselves, this is a randomized controlled trial from Turkey published, I believe, 2019. It looked at the use of ESP block in patients that were having 1 or 2 level lumbar laminectomies. All of these patients were started on tramadol PCAs postoperatively. The control group received no blocks. The intervention group had bilateral ESPs placed at L3, and they used 0.25% Marcaine. The primary outcome they looked at was opiate consumption in the first 24 hours, which was 28% lower in the ESP group. The secondary outcomes they looked at, in terms of pain scores, if you'll follow me to the table that's on the right side of the screen here, at rest, the ESP group had significantly lower pain scores in the first 8 hours. And with movement, the ESP group had lower pain scores that was statistically significant at every measured time point in the first 24 hours. The ESP group also took longer to receive their first rescue analgesic. So pretty promising from that publication. This is another randomized controlled trial looking at ESP block for lumbar decompression surgery. In India, they compared no block to 20 patients that received ESP block at T10. The primary outcome that they were looking at, again, was cumulative 24-hour morphine consumption. And so if you look at the table in the center of the screen here, the ESP group is going to be group 2. On average, they required significantly less morphine than did the control group, and significantly fewer patients required morphine at all in the ESP group relative to the control group. And again, the time to first rescue analgesic was significantly prolonged in the ESP group relative to the control group. In terms of the secondary outcomes with regards to pain scores, at initial score in the PACU, there was significantly lower pain in the ESP group, and then from hours 6 to 10. And again, this is kind of we should kind of think about this in terms of the context of how long are we expecting bupivacaine to last if we're doing it preoperatively, right? So we're doing the block, then we're doing surgery, then we get to the PACU. So kind of your start time on the bupivacaine is going to be at the time it's placed with the block prior to incision. Okay, perfect. So both of those were for laminectomies. What about fusion surgery? So this is a randomized controlled trial from China, published just last month. And so it looked at 1 to 3 level primary fusions, and all of these patients were started on sufentanil PCAs. These were relatively healthy patients. All of them were ASA physical status 1 or 2. 30 patients received just a kind of a subcutaneous saline placebo block, and then 30 patients received ropivacaine ESP blocks at L3. The primary outcome that they were looking at was pain scores in the first 12 hours postoperatively. And you can see at rest in the first 12 hours, both at 4, 8, and 12 hours postoperatively, there was a significant difference in terms of pain scores. However, with movement, there was a significant difference in pain scores at 4 and 8 hours postoperatively, but not necessarily at 12. If we look at consumption of sufentanil from the PCA, the ESP group had significantly lower PCA opiate consumption in the first 12 hours, and significantly fewer of the ESP group patients were requiring PCA sufentanil in the first 12 hours. And so in the 3 studies I've just talked to you about, our comparator has been ESP block versus no block whatsoever. So when I read that, kind of the natural question that I asked myself is, what about ESP block versus local infiltration by the surgeon? Because both in Denver and from what I've observed here in Seattle, local infiltration seems to be kind of the standard of care. And so although there's nothing looking at ESP block versus local infiltration specifically yet, we can kind of extrapolate a little bit if we look at another block. So this is comparing local infiltration by the surgeon to the Tlip block, or the thoracolumbar interfascial plane block. So this is also a study published from Turkey. They were looking at single-level discectomies or hemilaminectomies, and all of the patients were started on postoperative PCAs. The wound infiltration group had bupivacaine 0.5% to 20 cc's injected by the surgeon. The block group, the Tlip group, had Tlip blocks performed by their anesthesiologists using 0.25% Marcaine. And the primary outcome they were looking at was opiate consumption. And so if you look at the group that received the Tlip block, at every measured time point in the first 24 hours, that group required significantly less opiate than did the group that was receiving wound infiltration. Okay. If we look at pain scores, the Tlip group at rest had significantly lower pain scores in the first 8 hours, and then with movement also significantly lower pain scores here in the first 8 hours. And then in terms of opiate-related side effects, the group that received Tlip blocks had a significantly lower incidence of nausea, vomiting, and pruritus. So how the Tlip compares to the Erector Spinae plane block. So both with the Tlip as it was originally described and with the modified Tlip that was described in that comparison study that I just showed you relative to wound infiltration, what you're doing is essentially injecting local anesthetic between the component muscles of the Erector Spinae complex, and then that local anesthetic will backtrack to the primary ramus, the dorsal primary ramus, and then anesthetize that. With regards to the ESP block, we're depositing all of our local anesthetic adjacent to that dorsal primary ramus. So kind of intuitively, you would expect the results to be similar between these two. As an anesthesiologist who performs these blocks, and also as somebody who in Denver taught these blocks to many of my colleagues, the advantage that I would give to the ESP block is that because you have the tactile feedback of hitting bone in addition to the ultrasound guidance, if we use a basketball analogy, performing an ESP block is like doing a layup. Performing a Tlip block is like shooting a three-pointer. It's much more challenging, and in terms of making it very useful to many anesthesiologists, the ESP block is much more easy to perform. So as a result, I think you would have much more consistent results with it than you would necessarily a Tlip block. Okay. Very briefly, I'm just going to say that this is also something that we can use for for anterior approaches for lumbar surgery. So some of you may use tap blocks for that, but these can be very painful, surgeries. And sometimes if these patients have adhesions, they can have some degree of visceral pain that you wouldn't necessarily block with a tap block. But again, with the ESP block, one of our mechanisms of action is that there is some degree of paravertebral spread. So that, I think, makes it very helpful and useful if you're using an anterior approach. In terms of setting up an ESP block program, kind of from what I gained from my time in Denver was some of the necessary ingredients you need. Number one, you need surgeons that are willing to trial this on their patients. And it seems like from the email exchange that I was on last week with a few of you, that some of you are willing to try this, so thank you very much. Number two thing you need is sort of a strategy to prevent infections. So before we even talk about the block, you know, the incidence of infection with spine surgery is basically not zero. So before you roll this block out, it's important to know what is the incidence of infection that we're having right now before instituting this. And then when you implement or trial this block, it's important that your anesthesiologists do this in a very sterile manner. So if you'll follow the blue arrow to the image on the left side of the screen, when I was in Denver, the point that I emphasized to my colleagues is we need to treat this like central lines, gown up, glove up, prep out the area, use a sterile probe cover, treat this very, very sensitive, in a very sensitive manner, because we do not want anything that we're doing with this block to increase our baseline incidence of infection. So infection control is kind of a very important component of this. Another important component is having the right tools to perform the block. So because of the depth of target, you really need a curvilinear ultrasound probe. And as of last week at Cherry Hill, we did not have one, but my colleague, Rachel Cutteroff, has done an outstanding job in securing one of these. But in my opinion, one is not enough. And this is something we'll probably need our surgical colleagues there to help us out with administration, is that if you could imagine if there's 4 first case starts and 4 of those patients require ESP block, and we're competing over one ultrasound probe, that's going to cause some issues. So this is something that we're probably going to need to go to the administrators at the hospital about and say that, hey, we're going to need at least 2 or 3 of these things. With regards to the kind of the fourth ingredient is anesthesiologists that know how to do this. And again, Dr. Cutteroff has done a fantastic job. Basically in the coming few days, we're going to be having a couple of workshops for our anesthesiologists there, getting them facile with this. And I think that that's going to be very helpful. And then finally, you need a way to evaluate the impact that this is having if you do introduce this for your patients. So the nice thing is that with the electronic medical record, you can pull a lot of information retrospectively in terms of opiate consumption, in terms of antiemetic administration and things like that. But sort of developing that evaluation process is sort of something you have to kind of sort of first sit down and sort of assess what are the important variables to you that you want to assess. Okay. So in conclusion, with regards to the ESP block for spine surgery, the initial literature is very promising. But again, we have 3 randomized controlled trials at the present time with roughly small sample sizes. Okay. This is one additional multimodal tool to use. So my point here is that it's not necessarily to replace anything else. It's just another kind of weapon that we can add to our cachet that we're, you know, in approaching these patients. The third point, this is, you know, I think with the body of literature we have, this is safe for use in thoracolumbar surgery, but its use in cervical surgery is something that I think is still something that we need to let sort of the literature kind of play out and see where the chips fall. And kind of the final point, I think that this is an area that is kind of an area of active literature right now, and I think there's a lot of opportunities for research here. All right, so that was the final slide. Thank you very, very much for the invitation to speak today. Thank you all for listening. If you have any questions or anything that comes up after the presentation, feel free to email me. But if you guys have any questions at the present moment, I'd be happy to take them.
Thank you, Atta. Please accept our applause by my words. It's all virtual, but we have 10 people approved here in our audience room, and I really loved it. The chat room has a couple of questions, so let me just fire those at you. I think they're all helpful questions. So for instance, from Armin Kachatrian from Utah, why not use liposomal bound Marcaine? And then the next one, I'll just fire those right at you in sequence from Louis Quartararo. Why not do the block in the same draping to save resources as the surgeon? So just a quick 1-2 punch at you.
Okay, so with regards to liposomal bupivacaine specifically, my experience both in Denver and here has been that that's the biggest hurdle to using that is often the institution, right? Because liposomal bupivacaine is quite expensive. So some institutions do not even have it on formulary. So like when I was a fellow at Pitt, the entire UPMC system did not even have Exparel available on formulary. So that often is the biggest hurdle there. In terms of conservation of resources, I think that is a very, very nice point, and something that we should take into consideration. I think just from conservation standpoint, it might make sense to just do this, after we're prepped and draped immediately before incision.
Great, thank you. Roland, are you still on live feed?
Yes, I am.
Yeah, you do outpatient surgery. So have you done this, and what are your thoughts in terms of this technique?
No, I have not done this. I've had limited use with Exparel, but that was actually my question, and a great presentation, by the way, Dr. Rahman. I really appreciate it. Are there safety concerns in your mind for just kind of outpatient lumbar surgery? And primarily what I'm referring to is probably just short segment laminectomy and or microdiscectomy.
Right. With regards, are you talking with regards to Exparel, or are you talking with regards to the ESP block?
No, specifically to the ESP block.
Okay, perfect. So one of the mechanisms of action, so we talked about at the thoracic level, you'll have some degree of paravertebral spread. As we go lower into the lumbar level, you'll have some degree of lumbar plexus spread. So if you're doing this for outpatient elective back surgery, it's very important that you use either bupivacaine 0.375% or 0.25%, because sometimes with 0.5% bupivacaine, because you have that degree of lumbar plexus blockade, sometimes you can have quadriceps weakness after performing this. So when we were doing this for fusions, we were often using 0.5% bupivacaine, but whenever I did this for an outpatient spine type case, I would selectively use 0.25% or 0.375% bupivacaine to try and avoid the incidence of quadriceps weakness that you would have from that lumbar plexus involvement.
Yeah, thank you. I think that's a great talk. I think unfortunately our medical community has done us a bit of a disservice in really pushing opioids over the past several decades, and we're finding out the side effects associated with that. But if you don't mind, I may have some of my anesthesia providers reach out to you.
Yeah, absolutely. I'd love to field any questions. Absolutely.
Thank you.
So one other critical question, Atta. So you're obviously a very facile anesthesiologist. One question that came up in the chat room was, why shouldn't the surgeon just kind of aim for the L3 transverse process and just try to anesthetize better? So being more selective in our local infiltration.
Sure, and that's a great point. And I had, there's this, one of the surgeons that I worked with in Denver, Peter Suray, we initially did ESP block for him, and then he sort of asked himself the same question, and then essentially started doing it under fluoroscopic guidance himself. And so there's nothing that there's no studies yet, I think, that compare the two in terms of, there's no studies yet that compare, is there any difference in outcome between an ultrasound guided ESP block by the anesthesiologist versus a block performed by the surgeon under fluoroscopic guidance. So I think that that's a potential area that can be looked at, but there's nothing yet in the literature comparing the two.
Great. Well, we've reached the 8 o'clock hour, so thank you so much for a very thought-provoking and extremely nicely presented talk. And I want to thank our fellows also for their presentations today. This is an evolving field, as you said, and we're very much looking forward to partnering with you and Dr. Kudoroff on trying to explore how we can apply it to the benefit of our patients. So thank you, Atta, and talk to you soon.
All right, thank you very much.
Thanks for watching. Hit the subscribe button for more medical content.